Did you know that there are about 50 million people worldwide with epilepsy? What about the fact that about 80% of those people live in middle and low income countries? Now, what if I told you that an overwhelming amount of those people currently do not have access to diagnosis or treatment for their condition? This is referred to as the Epilepsy Treatment Gap, which is the proportion of people with active epilepsy who do not receive appropriate comprehensive treatment in a given population. But let's start at the beginning. What is epilepsy? Epilepsy is a chronic disorder of the brain characterized by recurrent seizures, which are brief episodes of involuntary movement caused by excessive electrical activity in the brain. The seizures that a person experiences can vary from brief lapses of attention or muscle jerks to severe and prolonged convulsions. They can also vary in how frequent they are, from less than one per year to several per day. Epilepsy is one of the world's oldest recognized conditions. However, stigma, discrimination, fear, and misunderstanding have surrounded the disorder for centuries, and even now continue to impact the quality of life for those with epilepsy. Epilepsy is most common in middle and low income countries, such as various South American countries, several African countries, notably Tanzania, Liberia, Nigeria, and Uganda, as well as India. It is most common in these countries because there is a higher prevalence of brain infections, traumatic brain injuries, and other infections that can lead to epilepsy in these countries. Also, nearly 75% of the people with epilepsy living in low-income countries do not get the treatment that they need. That brings us back to the treatment gap. As a reminder, the epilepsy treatment gap can be defined as the difference between the total number of people with active epilepsy and the number of those whose seizures are being appropriately treated. Across the world, under-recognition of seizures continues to be an issue, leading to diagnostic and treatment delays. This stems from issues surrounding lack of seizure recognition, stigma and public education, socioeconomic divides, as well as healthcare worker education and lack of basic access to care. In different regions, people may face language barriers, economic barriers, and technological barriers to timely diagnosis and treatment. Let's take a look at our first cause: lack of seizure recognition. Difficulties recognizing seizures is a prominent issue, often leading to delays in diagnosis and treatment, specifically seizures without motor manifestations or focal seizures, as they can be more subtle and therefore go unassessed for longer periods, as they may just look like someone is staring into space while being unresponsive. Our next factor is public education and social stigma. Studies have shown that although the stigma surrounding epilepsy varies by country and region, it persists in all regions regardless of resources, education, and income level. It is, however, worsened in lower economic countries where public education is poor. For example, a study done in 2005 in Rwanda found that of the people sampled, most respondents believed people with epilepsy should not be allowed to go to school, to work, to use public spaces, or to get married, and believed that epilepsy was untreatable and infectious. Another study in Senegal found that 51% of people believed epilepsy was caused by evil spirits. Social stigma creates discrimination against those with epilepsy. For example, in some countries, people with epilepsy may be banned from certain establishments such as movie theaters, restaurants, and other public buildings. Some countries even have legislation that makes epilepsy grounds for an annulment of a marriage. With increased stigma, you get a decrease in people seeking treatment, therefore a decrease in seizure control, and an overall increase in negative mental health effects. Our third factor is socioeconomic divides. One of the most significant causes of the gap are the socioeconomic disparities between higher and lower income countries. In many regions, there are ongoing issues with people not being able to access and afford anti-seizure medication, AEDs, let alone having more than one treatment option. Beyond basic access to medication, there are also stark differences in quality of life and quality of care for people depending on demographic variables. Our fourth factor is healthcare worker education. In developing countries, healthcare worker training in neurological disorders can be poor and misunderstood due to being in a resource-limited environment. In low and middle income countries, there can be a significant knowledge gap about epilepsy among primary healthcare workers. Also, there is a lack of training in recognizing seizures. Additionally, sometimes healthcare workers hold the same stigmas and beliefs against people with epilepsy as the general population does, due to a lack of education. This can further delay treatment as well as further perpetuate the discrimination against people with epilepsy. Our last factor discussed is a lack of access to AEDs, or anti-epileptic drugs. Up to 70% of people living with epilepsy could become seizure-free with the appropriate use of AEDs. However, in many low and middle-income countries, there is low availability of these medications. A recent study found the average availability of generic anti-seizure medications in the public sector of low and middle income countries to be less than 50%. This is a barrier to accessing treatment. Additionally, even if AEDs are available, the cost of them may not be accessible to some people living in lower income countries, increasing the gap further. A large systematic review for the World Health Organization published in 2010 reported a gap. Remember, this means the proportion of people with active epilepsy who do not receive appropriate treatment, to be 75% in low income and 50% in most middle and upper income countries. But the most striking finding was that over a 20-year period from 1987 to 2007, there was no improvement in this treatment gap at all. So, why should we care? Number one, those affected by the gap face a higher risk of premature death. In fact, one study found that the leading cause of death in people with epilepsy living in low and middle income countries are directly attributable to epilepsy, with 18.9% of mortality cases classified as sudden unexpected death in epilepsy. Number two, a higher prevalence of mental health issues. The stigma and discrimination those individuals face can leave them feeling isolated and discouraged from seeking treatment. So not only do they not have access to treatment, they may not also actively seek it. And thirdly, researching the etiology and potential treatment options in epileptic patients who reside in middle and low income countries can be extremely difficult. This is mainly because those affected by the gap are unlikely to participate in trials for research studies. This makes it harder to progress the understanding of the disease, thus perpetuating the treatment gap. How can it be minimized? The epilepsy treatment gap can be minimized. However, due to the magnitude of this issue, it often requires more extensive political and systematic healthcare solutions. Strategies to improve the gap will likely require a coordinated effort between individuals, communities, healthcare institutions, as well as governmental and non-governmental organizations. Firstly, governments and other organizations can provide healthcare workers with training and education on the signs of epilepsy. A study in Nepal found that it is possible to train non-neurologists to be able to diagnose epilepsy in middle and low-income communities. This demonstrates the power of education and awareness among healthcare workers. Education can be facilitated through web seminars, pre-recorded lectures, and other accessible learning platforms. Additionally, providing AEDs must be assured to middle and low-income populations. Such assurance could be provided through political intervention from the government or by working closely with the pharmaceutical industry to guarantee affordable supplies. However, none of these solutions mentioned previously will work if epileptic treatment is not recognized as a public health priority. But there has been some progress. The World Health Organization, the International League Against Epilepsy, and the International Bureau for Epilepsy lead the global campaign against epilepsy to spread awareness surrounding the disease and to strengthen public and private efforts to improve care and reduce the potential fatal disease impacts. Overall, the epilepsy treatment gap is a critical issue, mainly affecting those in middle and low income countries. The total number of people with active epilepsy and the number of those people who actually receive proper treatment in these communities is staggering and has devastating effects. However, with a coordinated effort between individuals, communities, healthcare institutions, and the government, this issue can be resolved by making epilepsy a public health priority.